Well, greetings and welcome to Epidemiology and Biostatistics. This is the DNP 903 course at Concordia University. I'm your instructor, Paul Hartlaub. Now, part of this unit is an icebreaker, which I have asked you to do, and I will go first and show you how I would approach it. It is to talk about the origins of your last name. So my last name is Hartlaub. It's German. There are two parts to it. The Hart means sturdy or strong, and Laub refers to the leaves on and twigs on the ground in the fall. So I think it refers to a sturdy harvest. At least that's the way I've taken it. My background is family medicine, also general preventive medicine and public health, and a master's degree in public health, which I received from the University of Colorado Medical School. I was full-time faculty in the family practice department at what is now the UW School of Medicine and Public Health for 14 years, and then moved over to Covenant, which then became Wheaton, which is now Ascension, Wisconsin, part of Ascension Health, which is a national Catholic healthcare system, nonprofit. I am currently, in addition to seeing patients about 3.5 days a week, I'm medical director for quality and primary care for the state in Ascension Medical Group, also medical director for Wisconsin for Ascension Care Management, which is a part of Ascension Health nationally and is a population health part. I am from Wisconsin, have 4 kids, 2 grandkids. My wife, Jenny, is a DNP, and she, in addition to having her own practice, is the ambulatory director for APCs, Advanced Practice Clinicians, in Advocate, Aurora. She was also in the very first cohort at Concordia in the DNP program. What I'd like for you to get out of the course is a foundation from which you can become competent and confident working in population health issues, a wide variety of them, such as quality improvement, perhaps academics, administration, public health, research, and just good, sound clinical practice. The course is going to provide tools for you. You will develop your own style, artistry, interests in the areas that you choose, and ultimately be competent in those, but hopefully this will lay a good foundation. You will be the expert, and the course will help you. You're going to get questions from people in your healthcare system or your group, such as these. Local GI doc advocates rectal exams as part of your group colorectal cancer screening protocol. You are asked to advise the group. So are rectal exams a good idea? Should we recommend that everybody do them? Are they a good idea or not? Another example might be, as the Hospital Quality Improvement Director, a staff endocrinologist gives you references for 2 recent New England Journal studies, one that finds tight glucose control beneficial and one that finds it dangerous. You are asked to advise on whether or not to change the goals in your healthcare system. So you want to look at those 2 studies, and you want to feel fairly comfortable deciding what to do based on those studies. Another example, a drug rep brought lunch for your entire clinic and wants you to give wawastatin samples out based on a single cohort study. You need to decide if that is sufficient evidence, or do you need more. You are a local county health department director. A local internist calls in with a report of 2 cases of salmonella in her practice. Where do you start? So there'll be a lot of examples like these, and my hope is that this course will help you feel a lot more comfortable in getting started working on some of these issues. The course outline goes like this. Unit 1, Week 1, will be an overview of epidemiology with some of the background about public health, the origins of epidemiology, where it came from, what its uses are. Weeks 2 and 3 will be an introduction to biostatistics. Actually, I know you've already had an introduction, so this will be in part review. Biostatistics is, of course, a lot about probabilities, or the art of never having to say you are sure. There will be formulas presented to you. However, they are not intended to be memorized. They are used to help you understand the constructs. Unit 4 Week 4 is about test characteristics, sensitivity, specificity, predictive values, and the like, and screening. So we will be looking at tests for screening and learning tools to help think about whether or not we should be screening, even though we know we can. So we could screen for ovarian cancer, for example. It's not been shown to be effective, so the question is whether or not we should be doing that. In Unit 5, we will be looking at an overview of basic study designs. To do that, we'll use an example of smoking and does it really cause harm. We can musingly look at whether the government actually was saying that it was bad for us when it really wasn't proven to be bad for us, or maybe the tobacco companies would be more accurate. But we'll go through all the different study designs and their level of evidence as to whether the effect is really from the cause. And then Units 6, 7, and 8 will look in more detail at the construction of and appraisal of case control studies, cohort studies, and clinical trials. Okay, let's get started. Okay, let me start with a story of John Snow. John Snow was a British anesthesiologist who lived in the 19th century between 1813 and 1858. He was very interested in cholera, which was an acute enteric disease and pandemic in the world in the 19th century. It's not pandemic now, fortunately. He hypothesized that cholera was transmitted through water. Bacteria, of course, were not known about at that time. In 1854, there was a noted outbreak in the Golden Square area of London. And here's a map of the deaths from cholera in that area at that time. You can see Broad Street in the middle of this area, and the large black dot in the middle is where the pump was. So John could see by plotting out these cases where they tended to congregate, and you really get the feeling like they're close to that pump. He did try to convince people that it was coming from the pump in some way, and it was not believed initially, but he finally convinced them to remove the pump handle. And the cases dramatically decreased. Actually, my understanding is that the cases began to decrease actually before he removed the pump handle, but nevertheless it makes a good story. Here is what the Vibrio cholerae look like. Sorry, it's a little fuzzy, but it gives you a general sense of it, what they would look like microscopically. And here's an actual picture of the pump in London without the handle. Investigating a disease outbreak is done very much like John Snow did, and he is often considered the father of epidemiology. And the steps go something like this. You first verify the existence of an outbreak. You then confirm the diagnosis of disease. So you have to provide a definition. You have to decide what is the disease that you're referring to. And that comes out in the form of a case definition. You characterize the data by person, place, and time, so who's getting it, where, and when, and then you formulate hypotheses about it, like John Snow did, like it's coming from the water, and test the hypotheses, which in effect they did by removing the pump handle. Then you can indicate any indicated intervention. So that's essentially what it is. And if you were to get a call as a health director, that's what you would do. You would go through these steps in terms of investigating a disease outbreak. And it really is an interesting thing if you get a chance to go through the process. It's kind of fun. You sort of feel like a detective, and are. Some of the applications of epidemiology, certainly the kind of thing that we just described, outbreaks, disease occurrence. I don't know that I've actually given you a definition of epidemiology to this point. It's coming up on a future slide here, but it's the study of the determinants and distribution of diseases. So that's what it is. So describing outbreaks and disease occurrence is certainly part of that. Identifying the risk factors, causes, and ways to prevent diseases. Planning and evaluating, like public health programs around water, air, food, etc., safety. Quality improvement projects, the plan, do, study, act cycles that you're probably familiar with, are really a kind of epidemiology of determining what the data is, developing interventions, remeasuring, and so forth. Developing practice guidelines is part of it. Protocols is really around the distribution and determinants of diseases, what really affects it. And clinical practice, of course, relies on epidemiology in terms of data and guidelines. So here's the definition of epidemiology, the study and distribution of the distribution and determinants of disease. Evidence-based medicine is very similar and somewhat of a tangent or offshoot of epidemiology, and here's one definition I found: the conscientious, explicit, and judicious use of the current best evidence in making decisions about the care of individual patients. So the best evidence needs to come from good studies of the distribution and determinants of disease. So it's really coming from a foundation of epidemiology. So I like to ask, if evidence-based medicine is such a great way to practice, what were we basing our practice on before evidence-based medicine? And here, next slide. Here are the totally non-evidence-based top 10 reasons providers give for doing what they do. Number 10, I heard it at a drug rep dinner. Number 9, Habush, and Rotier will get me if I don't. Defensive medicine. Number 8, I had a patient one time, so they base it on some individual experience that they've had in the past. Number 7, the American Cancer Society or the American Urologic Association or whoever recommends it. Number 6, it is, after all, the standard of care. Number 5, that's what Dr. Always Right does. I'm sure you know someone in your area that is always right. Whatever they say is absolutely right. So other people around them tend to do what they say is right. Number 4, I learned it at a conference last year. Number 3, one of my faculty used to do it that way, or one of my preceptors used to do it that way. Number 2, those guys in care management or quality improvement said that we should. And the number 1 reason providers give for doing what they do is there was that recent study in JAMA, I think. Actually, if one does not have good evidence-based recommendations, these are not necessarily terrible reasons to base your clinical decisions on. I think that if we know what works, we ought to use it. If we know what doesn't work, we ought to avoid it. And if we don't know, we ought to be careful. And that's really how to approach evidence-based medicine. Some general definitions. Disease is the physiologic or psychological dysfunction. It's obviously a very general sort of definition. Health is a state of well-being and positive functioning. This is viewed as not just the absence of disease, but actually positive functioning as well. Prevalence and incidence. Prevalence is the number of cases at a single point in time. So, for example, the number of people in the U.S. with diabetes on January 1, 2008. That is a prevalence. So it's a number at one time. Incidence is the number of cases over a specified period of time. So, for example, the number of cases of influenza in the U.S. between September 1st, 2007 and March 31st, 2008. So it's a number of cases per unit time. It's a rate. When you speak of a rate, strictly speaking, it would need to be incidence. If you talk about a prevalence rate, it's not really a rate. A rate is a number of things that happen over a certain amount of time. Efficacy and effectiveness is another couple of terms that's good to keep straight. Efficacy is a measure of the effect of an intervention compared well, of those who use it compared to those who do not use it. So, for example, with oral contraceptive pills, the efficacy, how well it works in controlled studies, is 99.75 per 100 women years. So it's very, very efficacious. The effectiveness is defined, it's a measure of the effect of an intervention among those to whom it is offered, whether or not they use it. So if you use oral contraceptive pills in a population, what actually happens? Some of them are going to forget to take the pill, some are not going to want to take it all the time, and so forth. So the effectiveness is what actually happens in the community, and with oral contraceptives, at least by one source, it's 93.8%. So you can see how there's a fair difference in how well it works, depending on whether the situation is highly controlled or not. Okay, validity and reliability. Validity is the degree to which a test measures what it is supposed to measure. For example, arm blood pressure cuffs accurately measure blood pressure compared to intra-arterial blood pressures, which in this case would be the gold standard. So it measures what it is supposed to measure, which is the intra-arterial blood pressure. Reliability, on the other hand, is the degree to which a test is consistent. So it may not be accurate. An example would be an NP who is hard of hearing might get consistently low blood pressures related to the hearing deficit, and this would perhaps be reliable, that is consistent, but not valid, does not actually represent the intra-arterial blood pressures. Okay, a few more terms. Endemic describes a disease as being constantly present with a usual frequency in a given population. So colds might be described as endemic in certain months in the United States. An epidemic describes a clear increase in the number of cases. So it's something that's not the usual situation. It's a clear increase in the number of cases over a baseline. So we have influenza epidemics frequently, where you get a large number of cases of influenza. Pandemic is an epidemic on a grand scale causing widespread sickness or death. So influenza pandemic would be a very aggressive influenza outbreak, for example, in many different countries or in a widespread area affecting a lot of people in a very harsh way. Descriptive epidemiology describes morbidity and mortality in the population. This is sort of the who, what, where, and when. It's looking at the data and organizing it and presenting it so that you can get a better feel for the data. Analytical epidemiology, on the other hand, describes the causes of morbidity and mortality in a population, the how and why. So it's really looking more for causation than just describing what's out there. The ecological model of disease is a model that involves three corners of a triangle, which are the host, agent, and environment, and describing an imbalance between those agents. So, for example, HIV might be caused by the agent being spread through host activity, such as unprotected sex, as enabled by the environment, which might be a lack of education in the host due to a lack of healthcare access. Immunity can be active, passive, or herd immunity. I think we're almost done with these definitions, so hang on just a little bit longer. Active immunity is the production of antibodies by the body in response to a vaccine or infection. So whether you get chickenpox or get the vaccine, you're producing antibodies, and that would be considered active immunity. Passive immunity is the acquisition of antibodies created by another host. So getting antibodies in the baby through breast milk from the mother would be a form of passive immunity. Herd immunity is protection from the spread of disease because of a high degree of immune individuals in the population. So it's felt that for measles, for example, if 85 to 90% of the people in the population are immune, that really protects the remaining 10 to 15% from exposure. It shields them, if you will. The people around them don't get the illness so much. Okay, incubation period is the time between getting an infectious agent and developing the signs and symptoms. So the time between getting chickenpox and developing a rash, for example, would be the incubation period. Latency period is the time between the start of a disease and the onset of signs and symptoms. This is like the incubation period, except it's not referring to an infection, but something non-infectious. So the time between getting high blood sugars and developing symptoms. A carrier state is a state of being without symptoms and yet contagious. So we have covered an overview of applications in epidemiology, definitions, and what it's used for. Next 2 units we'll be going over biostatistics.